Well, welcome, audience. It is noon on the East Coast of the United States of America, so it's C-Star time. Today, we're really delighted to welcome Dr. Lisa Edmonds, who will talk to us. And before I introduce Lisa, let me alert you to the fact that we will have spring break here at C-Star. So our next talk will not be in 2 weeks' time, but we will host Dr. Rebecca Jackson on Thursday, March 24th. So we'll have a break from the C-Star lectures. And she'll be talking about reverse engineering the cortical architecture for controlled semantic cognition. So looking forward to that one, not in 2 weeks' time, but actually in 4 weeks' time, March 24th. Today, I'm delighted to introduce to you Dr. Lisa Edmonds. She is the director of the Aphasia Rehabilitation and Bilingualism Research Lab at Columbia University in New York. She got her PhD from the University of Texas, Austin in communication sciences and disorders. And she's also a licensed speech pathologist. After that, she served at the University of Florida, and also as a research health scientist at the Brain Rehabilitation and Research Center of Excellence at the Malcolm Randall VA in Gainesville, Florida. And after that, she moved to Columbia University, where she is now an associate professor. Many of us know her for different aspects of her research, not least her development as the principal brain behind Verb Network Strengthening Treatment, VNeST, which is a treatment she developed to improve spoken production abilities in sentences and discourse in persons with aphasia. That's also what she's talking about today in her talk. Another line of research for Dr. Edmonds is to develop materials and protocols for bilingual assessment of aphasia rehabilitation, particularly noun and verb naming in Spanish. I don't think she's going to be talking about that today. But she will be speaking to us about VNeST. If you have questions, please feel free to start typing those in the chat box, and Lisa will deal with those after the talk, and I will moderate the questions that you type up, so you can start doing that during the talk. With that, the floor is all yours, Lisa.
All right, thank you very much. Let me get this going here. So thank you very much, Dirk, for the invitation. I'm really looking forward to talking to all of you today about Verb Network Strengthening Treatment, or VNeST. I'd like to acknowledge co-authors and collaborators that have worked with me on VNeST and funding site at the VA, as Dirk mentioned. So the first publication of VNeST came out in 2009. So this study has been out for a while, and it is being used clinically and also in some research as well. And so I really wanted to do a number of things today. I first want to talk about the clinical context in which we can use VNeST, review its theoretical and clinical foundations, provide examples of the protocol with principles of implementation. And this really came out a lot of working with clinicians and training people on VNeST to sort of help them through some clinical decision making. Also consolidate some of the findings from VNeST research and talk about clinical implications, and also discuss a recent adaptation of VNeST with a clinical example. So we all know that aphasia is an acquired impairment of language that can affect communicative and social functioning and the quality of life in a person with aphasia and their family. Can also negatively impact a person's identity and sense of self, social networks, and life participation. And all these things can result in social isolation, depression, and psychosocial consequences. And I really want to acknowledge before we start the talk that all of these aspects of a person and more really need to be considered when we work with people with aphasia, as is seen in the AFROM model here. But today, necessarily, I need to focus in on VNeST and some of the language impairments and goals that we have around it. And it is a treatment that tries to improve generalized word retrieval. So that's where we're going to start and stay through the talk. So we're going to start with sentence production. And Meredith is a 62-year-old African-American female, 3 years post-ischemic CVA with a moderate Broca's aphasia. And we're going to consider at first just sentence production for single context, like a man is sweeping a floor or a carpenter is measuring lumber. And some things we want to think about: is there a basic sentence frame in the sentence, just a subject, verb, object? Are the words that are produced relevant to the topic? This is getting at lexical retrieval. Do we know specifically who is doing what? And how efficient are they at getting the meaning across? We're only doing this right now in spoken modality, but you can do this with writing as well. Okay, so here's a sentence. You don't know what the picture is because the question is the meaning being conveyed? The man is, oh God, the man is, I can't. So we see the beginning of a subject, verb, object, or a full sentence, but we're missing the main verb, and we don't know what the target is. And here we have a man eating a hamburger or a sandwich or whatever. Here is another example. The man, woman is, the woman is sitting, no. All right, the woman is sitting, no. Eating, no. All right, the woman is, I know. So she knows obviously what it is. And we are getting a complete sentence here. The woman is sitting or the woman is eating. When in fact, though, the woman is stirring a drink. So again, we have some lexical retrieval issues that are kind of preventing meaning and also complete sentences. So hold on to that for a second. Now let's consider John, who's 1 year post-hemorrhagic stroke and craniotomy with a moderate jargon aphasia. And here is his response to one picture. He is having ice cream, that's it, I think that's it. 2 of them, 2 things, and he's frying them out. And he's a man, and he's sort of nice right now, but old guy, didn't, doesn't, now old. He's old actually, I think. And the things here with a oh so close, he rides with a horse. So lots of fluency, lots of sentences, but meaning's probably not very clear. The picture is a cowboy frying eggs or making breakfast. So fluent sentence structure, clear word retrieval difficulties, very inefficient, and meaning isn't conveyed. So these 2 examples kind of get at kind of the clinical crux of where we can start with VNeST. So for more non-fluent folks, the goal is to increase production of core words in a sentence, like a subject, verb, object, and to increase the specificity or the accuracy of those words. For people who are more on the fluent end, to increase specificity of the words in already fluent speech and reduce pronoun nonspecific language and jargon, that sort of thing. And at the heart of both of these is our issues with word retrieval. So the clinical goals of VNeST then are to improve lexical retrieval for words in sentences and or discourse that are not trained. This is not a compensatory strategy. It's very bottom up, thinking about what can we do to promote just an overall increase in lexical retrieval. And so generalization is one goal. Also to improve the person's ability to produce words that are more closely conveyed to the intended meaning of what they intend to say. And there we need specificity. We have additional goals of that it be salient, relevant, and engaging, that it be multimodality, and that it could be implementable in other languages. So then what is the verb network? So when we think about a verb, oftentimes if we're to describe it, there's a person or there's some entity doing something. So for measure, there's somebody is trying to get the length or the amount of something. But when we think about, the semantics and what certain verbs mean, there's oftentimes kind of typical people that might do certain actions, like a carpenter measuring lumber. And priming studies have indicated that there's a neural coactivation whenever a verb or its closely related nouns, which are thematic roles, here the carpenter and lumber, are selected in a relevant context. But then verbs are also the syntactic core of a sentence, and they specify the argument structure of the verb, right? So subject, object, indirect object, 1, 2, and 3 place verbs. In addition, verbs can have lots of different scenarios and people who do people and objects, right? Agents and patients. So we can see a variety here. And for something with like chef measures sugar, with a cup in the kitchen, those are additional thematic roles of instrument and location that also kind of engage the semantic network. So how does this relate to the goals that we've already specified? Well, thematic role assignment involves knowledge that is highly specific to events denoted by individual words. That gets us to specificity, which is what we really want. Thematic role concepts are formed through knowledge and everyday experience, and verbs activate event and autobiographical memory in part from that. So then it is salient, right? And one verb can have a multitude of related thematic roles, potentially activating a large network of events or scenarios that can potentially promote more generalization, which we definitely want. And if we look at this pictorially, we see that there's just a lot of possibilities around verbs and semantic concepts that they activate. Keeping in mind that if we are activating this network, we're also strengthening that basic syntactic core of a subject, verb, and object. Wow. Sorry. Okay, so a little bit more about generalization then. So if we could if we could strengthen this network, we could potentially get generalization to maybe semantically related networks, but really thinking more beyond that, if we can sufficiently activate concepts around verbs, that there might be a larger network so that we can get more generalization. That's sort of the thinking behind it. So very briefly, to connect some of the protocol with what we just talked about. So if we want to strengthen this network and activate it for folks, that's what we do in the first step. So we basically are asking about the agent and patient, who measures things. I'm not going through the whole protocol here. There's a written tutorial and other information about it. But the why of this is important, right? We're trying to activate and strengthen those networks that we just talked about. There's also supports for people to do this, queuing that I'm not going into, but just so you know that there is support and queuing to help. The second step, a lot of times that first step is people are doing one word, then they're doing the other word. The second step allows them to read these responses aloud and kind of consolidate it within a sentence frame. And again, there's support from the clinician as needed. Then they choose one of the scenarios that they just finished and make a more complicated sentence. My wife measures windows in the living room last weekend because we need new curtains. So here we're adding semantic complexity, syntactic complexity, but it's also a really great place where people will oftentimes go into more detail about something they want to talk about that's more personal or relevant. And this is a lot of language for a lot of people, and it's supported though throughout. So I'm not going to really talk about these next steps for the sake of time, and we're going to focus on these first three. So I'm gonna hit this point hard. So the idea here is that these networks are clearly going to be different in some ways across people. There's going to be prototypical knowledge that we all have around, who measures things and so on. But we want to be thinking about the individual that we're working with and not just thinking about kind of, doing a protocol and filling slots. So we might have all these different people, and for a verb like build, someone might have something prototypical like construction workers build a house, but also these are actual examples. I built surfboards in Hawaii when I lived there because I love to surf. So here we have something very specific. Or my children build forts on rainy days with couch cushions. So this is a really important point, and it brings me to some key principles that I'd like to mention here. So I tried to really make this as consolidated as I could. And like I said, this has really come out of working with clinicians and training people on VNeST, because a lot of times people have questions that can be answered by these principles while still following the protocol. So focus on meaning. This is a treatment about meaning. So for example, we don't worry about phonemic errors and things like that. If we understand what somebody's trying to say, that's what we focus on. And we want them to know that that's what we care about, is them conveying their meaning. We promote independence and effort. Everything is an independent attempt first and then supported after that. We encourage salient, relevant personal responses. We encourage variety of scenarios over time. That gets at that breadth, semantic breadth, and hopefully to help generalization. And meet them where they are. The people that we've worked with aphasia and that are in the literature have a real range of severity. And so we don't need to adjust the treatment, we just meet them where they are with that. I'm just putting this here for maybe people who haven't seen the treatment or just to try to get a visual on it. In early articles, I talked about index cards, using index cards to put the words out, but I really don't think that that's very natural and it's not very collaborative. I would really like to encourage more collaborative work with VNeST, especially if you include writing, which I'll talk about. So these whiteboards that you set in front of you or even a pen and paper work really well. You can also do VNeST on a computer. We've done it quite a bit, just on a computer and in an office or via teletherapy. And you simply just use a PowerPoint presentation with text boxes and it works beautifully. Okay, so I'm just going to give a couple examples about these principles, but hopefully it gives you the idea. I will say if there's anybody who is doing VNeST or wants to try VNeST and wants more examples like this, I am happy to provide those if you email me out. So here we have a verb drive, and we see that there's different responses for different people. So I drive van is Bob's response, and a conductor drives an Amtrak train is Tamika's response. We see that the lexical nature of the verbs words is very different, right? Tamika is also including functors, a conductor and an Amtrak, like a, an, and the, and also inflecting her verbs and so on. But Bob didn't include those things and his sentence is simpler. That's fine. I don't, this is a question I get from almost every clinician. What do you do with the functor words if they don't produce them? You just don't worry about it. You focus on meaning. If we start focusing on, oh, we need to put a the here and an there, we're not focusing on their meaning. And that's what we're really trying to do here is focus on that, the semantics. You see here also Maria says dad drives a speed bore instead of speedboat. We don't correct that because we know she means speedboat. So we just say, oh, your dad drives a speedboat. That's awesome. So again, not like we don't do pull out where we start working on other stuff. And I think this is really principal and important to the outcomes of the treatment. I don't think it's just a technicality. That's my perspective. So a little bit about writing. We include writing with everybody now, and we have, you know, from the beginning to some extent. So you could do it with typed or written. It increases engagement, adds functionality, especially for people with apraxia of speech or other phonological output issues. It's highly motivating for a lot of people. They really like to not just do spoken, but written responses. I encourage having them try to say the word first before they write it. So let's look at an example over here. So Maria, let's say, is going to write her response. So she writes dad, and then she writes drives. Now the verb drive has already been provided by the clinician. So she can actually just copy that or not. And then speedboat is not spelled correctly. So the way we deal with this, unless there's only one grapheme missing or off, we give some feedback. Wow, you got a lot of the letters there. I totally get where you're going with that. And then we provide a written model. And then Maria, in this case, would use that written model to either fix the word or rewrite it. So it's essentially becomes a copying task. But the idea is that she's doing it herself. I'm not, or the clinicians are not going in there and fixing it for her. That's that promoting independence and effort. Even if it's something like I drive and just a V, then again, that's great. You started with the correct first letter, then we would give the model and then they would correct it. So they've generated all of this themselves and actively involved while having some appropriate supports while still focusing on meaning. One other example I want to talk about is refining and clarifying meaning. This is really important. One of the things we want to do is help people to convey the ideas that they want to express. And if we kind of just take responses that we're not really clear about, then we're not allowing them to do that. So here's an example. The boy kicks the basketball. So this is plausible. And oftentimes when I get a response like this, I might say, you know, I'm curious about the intended meaning. Tell me more about what you mean here, because I don't know if basketball was meant to be soccer ball. I don't know if they're thinking about some situation with a basketball, but I know that something semantically just isn't quite right because we don't typically kick basketballs. And so this then becomes more collaborative in terms of trying to get to what their meaning is and help them get there. And you can use drawing and pictures and whatever you need to do to kind of get there. I'll jump to this example down here. Jack is pushing candy. Who's Jack, right? If I don't know. And then what does this have to do with pushing candy? There might be more to it, and I just don't know unless I ask. So again, it's very important to do this. Also, sometimes semantic distinctions aren't clear, right, in persons, people with aphasia. And so this helps to clarify those semantic distinctions. One last example, that third step where people can add where, when, and why. This is an example somebody produced. The football player kicks the field goal in the Dallas game in the 2019 Super Bowl because of the football. First of all, it's an awesome sentence, but because of the football doesn't quite make sense. We don't know exactly what's going on there. And that why can be really difficult. And this is what's nice about the treatment, that it can scale for severity, right? So even somebody who's more on the mild side is still maybe going to need some work at this level as well. So you would want to go through that and clarify or try to understand better what the why is about. Last example with respect to principles, I do think variability is super important to generalization. I also think it's really important for participant engagement and for it to be relevant so that they're not doing the same thing every time. So here's an actual example that Nana boils potatoes, and then we have a chef and a cook boiling corn on the cob and carrots. Now, remember, there was one principle of meet them where they are. If you're working with someone and these responses are really, really good for them, you're not going to then try to promote more variability. You're gonna see that as a win and move forward. But in this case, the clinician knew that this person had maybe talked about some of these things before and had more language. So again, the idea is not to say there's anything wrong here, because they're totally fine, to just say, point out that chef and cook are semantically similar, so are the vegetables, and then model sort of thinking about another semantic category. Can you think of someone who boils something in a lab? And this person immediately was kind of excited because he was like, oh, I know, and then got out chemist and water. So a couple things. This provided an appropriate challenge to the person and modeled this so he can start to be thinking about other semantic categories and also hopefully to broaden for generalization. And these are just a few examples, I won't read these, of different kinds of responses we've gotten to give you an idea that there is a large variety, because it might feel like, how are you going to get all this variety around these verbs? And I'm always shocked. I chop a banjo. That's actually a method on the banjo. This was a professional banjo player. My ex-wife knits covers for our toilet paper rolls. You know, I read the funny pages. Judge reads constitutional law. It's a lot of language. But then the question is do the responses actually vary over time? And I wondered that. I mean, it's what we had hoped for. So in one clinical trial, we had 11 participants and we just went back and looked at all the responses. And what we found is they provided roughly 140, an average of about 140 different agents and different patients over 10 weeks, right? That's the subject and object. But are they the same that they use over and over, or how does that go? So on this right, what you're seeing here is that in the first 5 weeks, about a third of the responses were unique to the first 5 weeks. In other words, they didn't repeat in the second half of treatment. In the second half of treatment, there was another third of unique responses that we saw. And then there was another third at the bottom here that kind of continued throughout. And some of those might have been more personal, for example. So people do continue to vary and add interest as you go along. I also want to mention treatment fidelity, which is obviously very important in treatment studies. And so the studies that we've done that I'm going to review very briefly here, we've looked at 25% of the sessions and gotten greater than 95% reliability. But recently, another group, Conlin et al., and as part of a larger study, used VNeST to look at kind of comparing distributed versus intensive treatments. And so they looked at the fidelity in VNeST for 52 people, 32 people, 15 with apraxia, with a variety of folks. And they looked at 20% of randomly selected sessions, and they also got greater than 95% treatment reliability across the different cohorts and types of aphasia. So this is really good news to know that you can have people with different levels of severity, but still stick to the protocol. I'm not going to go into details about the verbs, but I do want to make a couple points, especially for people using it clinically. I think sometimes people think they have to use the verbs that are in treatment articles, but there are a lot of constraints around some of the verbs we choose in research. So I would really encourage people to work with the people with aphasia that they're working with to come up with more personal verbs. But a couple things, you don't want to choose a lot of verbs that are super semantically related to each other. So you would not train, for example, throw and kick. They're too semantically similar, and what you might cause is semantic interference rather than distinction. So that being said, I emailed a clinician, a master clinician that I know who really espouses the LPAA approach or life participation approach for aphasia. And just asked her if she had any interesting examples with VNeST, because she uses that a lot. And these are her words, and I thought they were nice to share to show how you can work with people. I had a commercial fisherman who was very stoic and quiet, did not get excited about much until I used the word measure. We, of course, related it to fishing, and it opened him up so much. He got out his phone and really started to connect and try to communicate more. Together, we came up with other verbs such as scale, dredge, cast, etc. I had no idea how many different nets and specific verbs they use. On our last day, he actually brought in a big igloo cooler with a whole fish on ice for me. So again, this is a great example of working collaboratively and making it personal, but also working on lexical retrieval. I had a younger guy who really was fun, but a complete party guy. He was not really motivated at first. During our collaborative goal setting, he talked a lot about his hobbies, which primarily consisted of beer making and growing pot. So of course I let him choose verbs, and we added ones like brew, ferment, pick, filter, etc. He got really into it and would bring me in all sorts of pictures. I had to even stop him once when he tried to bring in some samples. So I think these are great examples to hopefully help those of you working clinically to think about how you can do that. Okay, so now we're going to pivot into kind of research questions that VNeST has asked and a summary of results and implications. So in general, we've asked the following questions. Do we see improvement after VNeST with the ability to retrieve spoken words in untrained, single words, sentences, and discourse? Do we see a decrease in aphasia severity and an increase in ratings of functional communication by communication partners? These are all generalization measures. Since we looked at discourse, very briefly, I'm going to familiarize you with the measures. One is the correct information unit, or CIU, which is a word level measure of informativeness. So if you look at the picture here and then you look at this top description, what you see in blue are correct information units. They're relevant to the topic. So dog runs, man in tree, so on. So the interpretation here is that 36% of the words are relevant and informative related to the target. The other measure is a complete utterance, which was developed for VNeST, because the idea in discourse was, can they increase their ability to retrieve words within a complete sentence frame? We wanted to look at both. So what we do is there's two prongs to this. First, we look to see if an utterance has the subject, verb, and object. This is just what we did at the beginning of the talk. So dog runs is an SV. It's also relevant to the topic, so it's complete utterance. Man in tree is also relevant to the topic, but there's no verb, so it's not a complete utterance. So you do this all the way through, and you get percentages of SVO, relevance, and also the complete utterance. So you can keep that in mind when we look at the results. So we're going to talk about 22 people with a range of aphasia severities, which is on the bottom, and ages. The colors are the different types of aphasia. There were 19 English-speaking people and 3 Korean-speaking folks in this. This is from a review article. So there had been a study done by Quag et al. In Korean, so I included that at the time. There was a range of AQs from 36 to 88, and the dosage was anywhere from 4 to 10 weeks, about 3 to 3.5 hours for most people. For the study in Korean, it was an hour and a half. I also want to acknowledge that that there is a recent review of verbs and sentence treatments. Down here is the reference of Hicken et al. In 2021 that reviews VNeST among other treatments. So there's an independent review also for your consideration. So the results then from this study, the way to look at this graph basically is along the left here are the different outcome measures, and on the right is the percentage of people who showed improvement on those measures. So we see across all the measures, at least half of the folks improved on some element. So aphasia severity, 73%, sentence production, 70%, verb naming, noun naming, 84%, complete utterances, 53%, and CIUs, 47%. So we see then that these are generalization measures. They weren't treated on these, and we are seeing generalization across a variety of measures. And of course, not everybody is improving on everything, but we are seeing at least half of folks improving on something. This is just a snapshot of what some of the scores look like. I'm not going to go through all this, but what's in yellow showed improvement. So these are 4 different people, 2 with non-fluent aphasia, 2 with fluent. And these are all the measures. So you see that we are getting some nice improvements. We're going to look at Rich's sentence production here, though, to give you a flavor of how that changes sometimes in folks. So for this picture, the nurse is weighing the baby. He said, she is having a baby, damn it, she is, I don't know. So he has an SVO, but he can't get the words. Post-treatment, the nurse weighed the baby. One more example for this picture. Pre-treatment, he is having he is getting the I don't know. Post-treatment, the father, then he self-corrects, the farmer is driving the truck and towing the trailer. So now he's able to get all the words, but also expands the sentence as well. Another study I just want to mention is one that we did with people with aphasia and apraxia of speech. This was done via teletherapy on the computer. And we wanted to introduce writing with them because, well, we wanted more multimodality treatment anyway, but also because of their apraxia of speech. These folks really struggled in connected speech. Between agrammatism for P1 and apraxia of speech for P2. And this is a snapshot of their results. What you see kind of in green and bold is what improved. So we see the aphasia quotient improving for P1. Writing, this is the writing subtest of the WOB, improved for both participants. In terms of naming, we have improvement in spoken and typed naming. As you can see down here, spoken verbs didn't improve, but the others did to some extent. I wasn't sure what we would see for discourse for these folks, to be honest, so I was pleasantly surprised. First question was, could they just get more out? Because again, the spoken modality was very difficult, but also typing. So for participant 1, we see an increased number of words, as you can see there, almost doubling in both modalities. We also see in the spoken modality, complete utterances improve in discourse from 7 to 20%, decrease in pause time, so a little bit more efficient. And in the type modality, a decrease in neologisms from 25 to 2% and attempts at more complex sentences. Participant 2 only improved in the spoken modality, but again, it was all positive due to his apraxia of speech. So we see an increase in the number of words he got out, and the complete utterances also improved. So he was able to integrate more lexical retrieval within a sentence context. His rate improved from 14 to 26 words per minute, still very slow, but we saw some movement there. But there was no improvement in the type modality, and I'm happy to talk about that in questions. So some general implications then, people across a range of aphasia severities can do VNeST, but they can also show generalization across a lot of measures. It's feasible via teletherapy. It can be adapted for individual differences, but stay consistent to the protocol. And there's some examples there. A couple other things. Sometimes there's this thought that people sort of have to improve bottom up. They have to get better at naming, then they get better at sentence production, then they get better in discourse. And what we see in this study is that there's not that kind of pattern. Some people improve in naming and discourse, or sentence production and discourse, or whatever. If one doesn't rely on the other, at least from our results. So you really need to have a hierarchy of outcome measures to capture where people are improving and where they're not. We also didn't see any discernible predictors of improvement like severity or type of aphasia or cognitive scores. The potential efficiency of VNeST, I think, is a really important clinical implication. So we found that by training verbs and nouns as a cohesive unit, we saw robust generalization to single nouns and single verbs. I haven't shown you this yet, but I'm gonna in a minute. In sentences, we train these two-place verbs, right, that have a subject and object. But we've seen in our sentence production data that there's a robust improvement to one-place verbs in many participants. So the implication is you can work at the sentence level and potentially get improvement to single words. And you can also start with more complex verbs to get improvement to simpler verbs. You don't have to start with single words and kind of move up. And so this is consistent with the complexity account of treatment efficacy, that you can train a more complex component of a structure and get improvement downward to simpler forms. And at the same time with VNeST, we can see that as a potential, but also the potential for discourse to improve as well. So it's important to consider these things in terms of, making decisions in treatment in terms of how much improvement we might get, especially when we have limited time with folks. I'm just going to mention here with functional communication, we only looked at this in 11 people and asked for communication partner ratings. The results were very positive. Everybody noted an improvement, but we need more measures across other domains for sure. We have anecdotal feedback from people as well in terms of increased phone use, communicating with medical staff and so on, but we definitely need to do more work in this area. Okay, so we've been kind of looking globally. I'm going to just take 2 slides and we're going to get in the weeds a little bit here. And we're going to think about potential mechanisms of improvement that we might see at individual level and how that might relate to people's pre-treatment profiles. So we went back and did a really detailed analysis of 11 people in one of our studies, and we created these pre-treatment profiles looking at grammatical class deficits, a lot of elements of sentence production abilities and so on. And we wanted to see how that related to their outcome measures to see if we saw any patterns. This next slide's a lot, but let me I'm only going to point out a couple things here. So this is one of the graphs from the study. And you can see what we've done is we actually kind of put people on a hierarchy of impairment from at pre-treatment. So the people on the left here were more mild, and then they got more severe as we moved forward. And I'm not going to go into it any more than that, just orienting you. The bottom 2 graphs here are their results of naming and sentences. But what I really want you to focus on is up here. So if you look at the star, what you see below the star is these 2 folks improved on complete utterances, right? So that's that integration of SVO and relevance in discourse. But then the question is, the question is, what drove that? Like, what's the mechanism? Is there a way we can get at that? So if you look above there on the participant on the left, that dotted line is telling us about lexical retrieval, or the relevance of the words they produced in sentences and discourse. The dark line is telling us their ability to produce a subject verb object. So their ability to create the sentence is much better than their ability to retrieve words. But post-treatment, you see that the lexical retrieval improved and met the subject verb object abilities, right? So that gets at some of the mechanism of what's driving the improvements in sentence production. The person next to that person, you see the opposite trend. You see that SVO is much lower than relevance. And you see that oftentimes with people who are more non-fluent, who can get a good number of words out, but they can't complete the whole sentence. So the idea here is that, again, there's way more here that we can talk about, but this study is published if you're interested. But you can get more at individual patterns if we start looking at these things. Last thing I'll mention is I told you about improvement of one-place and two-place verbs. So you can see here this gray line is two-place verbs that are improving. The dotted line is one-place verbs that are improving. And we see that across a number of people. So that's what I was saying, that we're seeing improvement, not just on two-place verbs, but one-place verbs, and in a number of cases, three-place verbs as well. Okay, now we're going to pivot again, because like I said, I'm trying to consolidate things. VNeST was intended to be adapted to other languages. I'm not going to go into these studies, but I did a search to kind of see what was out there. A lot of these are conference abstracts, so they're not published as full papers just yet. But all of them said that VNeST was feasible in these varied languages. So I first just want to acknowledge that and say, if you're working with people and you want to work in another language, you simply, the syntax of subject, verb, object, you move that around for what's appropriate to that language, and any other language specific modifications you need to make. That was the intention. It's not syntactically specific to English. In terms of bilingual findings, a few studies have started to ask a really common question in bilingual aphasia, which is, if you treat one language, do you see generalization within that language into other languages? And this is a study by Ra et al. This is a different group, and they asked if they trained in Mandarin, would they see improvement within Mandarin into English? And one of the reasons we can ask this question, especially with semantic treatments, is that the semantic system for bilinguals is shared, especially for concrete items. And so if you activate that, you can potentially get improvement to both languages. So briefly, Ra et al. Did find improvement in the trained language with cross-linguistic generalization to English across multiple measures. Lerman et al. Have found in a couple studies improvement to the trained and untrained languages in English and Hebrew with various patterns of improvement. And also Lerman et al. Have looked at using VNeST with English Hebrew bilingual with logopenic variant of PPA, and their conclusion that it may be a prophylactic treatment for the preservation of lexical retrieval. That was with one person. It's very new and preliminary, but I'm just trying to share some of what's out there with you, if that helps give you ideas. Okay, so this is the last part of the talk. So after we did that really detailed analysis of participants, we thought some people could actually have gotten greater generalization. And what we thought related to that was that they were still using pronouns, even though we knew their lexical retrieval abilities had improved, and more general verb retrieval. So doing things like using verbs like doing and going. And we really thought a lot of this for some people was related to reduced self-monitoring. So here's the original VNeST protocol. We have a new step that we're trying here as step 5. And basically it involves a picture. We provide a picture and we ask people to make a sentence, including a subject, verb, object, to use specific words, not general words. And then we ask them to actually self-monitor to see if they've done all of those things. So it makes the SVO structure more explicit, but also the idea of using specific words. It is really important that you use different verbs every week with this, or different pictures. This is not about learning the picture, it's about the process of being specific and self-monitoring. So it has to be a different picture every time. You can use fun, relevant, personal pictures, but whatever it is, change up the picture. And people really like this step. So this is the last person we're going to talk about. So we use the adapted treatment for a couple of people, but I'm going to highlight Paul here. So he came to us with a mild anomic aphasia because we were running a study on written discourse. And his goal was to improve his written discourse. but his written abilities did not meet the threshold to enroll in that study. So we enrolled him in VNeST with the adaptation. And so here is his spoken discourse. I won't read all of this, but we've got this little narrative here. And he does a good job of basically kind of talking about the story. But there is still a lot of pronoun use and some empty language, not just with this picture, but in his other discourse samples as well. And he had poor self-monitoring around that. He just wasn't aware that that wasn't informative, and sometimes people didn't always know his meaning. Now let's contrast this to his writing. This at the bottom, what you see there, they are fighting over the house. She left to come back to the house with the car sack. There's a car crash in this last picture. That's what he's talking about, is all that he was able to write here. And this was very time consuming and effortful for him. And this is what he wanted to work on. He really wanted to write more so that he could more functionally be involved in writing. So we enrolled him in this. So we just adapted VNeST that way. He's doing spoken and written responses. So we see here, not really a change on the WOB spoken, but we see his writing on the WOB improved quite a bit from 62 to 95. We also see that his written naming on both nouns and verbs improved. His oral naming was already quite good. We also gave him the ACOM to get his feedback on functional communication, and he expressed some improvement there. And that measure does ask about spoken and written and language. Now let's look at his sentence production. You can see pre-treatment, it was really low. And post-treatment, he improved both on the spoken and written modalities. There's an example down there. He went from he is pouring a drink to the man is pouring a drink for the boy. And we think some of this increase in specificity is due to some increase in self-monitoring, or at least self-awareness around it. Also want to just mention writing is very helpful in terms of visual feedback. Even if you write it, having that as visual feedback for them to make these meta decisions about is helpful. If they're writing it, there's just a whole other layer of feedback. So what about discourse? This was difficult in both cases for him. And so we see so on the left here is number of words. So you see there's a big difference between spoken and written to begin with. But in both cases, we do see an increase in number of words and increase in number of utterances, which is great, but is it meaningful? Just more isn't better. And it is meaningful. So on the left here, you see correct information units, that word level measure of informativeness. It improved both in the written modality and in the spoken modality. Complete utterances also improved in the written modality and spoken modality. So he's integrating more lexical retrieval within that subject verb object frame. So here's where we can look at this possible mechanism and a little closer to see, to help you make sense of it. So on the left here, now we're looking at SVO and relevance. So in the spoken modality, you can see here that SVO was better for him than relevance or lexical retrieval. There's a lot of the pronouns and empty language, right? Post-treatment, we see that both improve. So there's like this kind of parallel increase in both. In the written modality, we see that the subject verb object was he can produce a frame in the written modality, but the words he's getting out aren't as informative. Post-treatment, nothing changes in his ability to create a form, but his lexical retrieval improved, and that's what's driving the improvement in complete utterances. So here's an example of what that looked like. So here's the pre-treatment example over here. He enumerated this, and he now has a sentence for every picture. He tells a complete story that makes sense. And the only word he's really not getting right is still like car crash. He has the fighting ends with the car skirt. So you see that there's movement, right? So his feedback was that he really liked sitting and working at the computer. For him, it felt like work. He used to go into an office. He really liked that. He liked that it was challenging and that he had to work hard. He reported that reading was become easier, but it was still effortful. But the good news is that he then qualified to go into the writing discourse study. And so the point here is that if we think about treatments and approaches over time, he's able to now leverage what he did here to move into working at a higher level. So VNeST has been shown preliminary efficacy to promote generalization of word retrieval across conditions. It's multimodality, adaptable to other languages, very focused on meaning. It's important to apply the principles behind the protocol to maximize engagement and potential outcomes. The new step may promote increased self-monitoring, which can improve outcomes. As I mentioned, it can be used, we didn't talk about this too much, but it can be used with other treatment approaches or concurrently or over time, depending on the express goals and needs of the person with aphasia. Again, going back to the AFROM model and thinking about their overall picture. And more research is needed to understand dosage, pretreatment profiles, mechanisms of improvement, and we need much more varied outcome measures consistent with the AFROM model and more. So thank you very much. I'm happy to take questions.
Thank you, Lisa. As always, you cannot hear our audience applauding, but you know they are.
It's
know
okay.
they are. I have to say, I found it very hard to pay attention after you mentioned that you built surfboards in Hawaii.
I did not.
That made you. Oh, okay. I thought
No, that was a person. That would be lovely. No, that was a person with aphasia. That was one of his responses.
All right.
That was his experience.
I thought you just won C-Star.
Oh, no.
That was not. Okay. All right. All right then. No, I did actually end up paying attention. Thank you. So first question from Danielle Fahey. How much do the treatment effects rely on word order of the language? Are there any notable differences in treatment strategy or in improvement of verb final languages such as Korean? Or would VNeST work in a language with much freer word order than English, or in a language without a strong verb-noun distinction? For example, Salish.
Well, I'm not a linguist, and so I hesitate to try to get to seem too knowledgeable about this. I know that it has been modified for a number of different languages, more than what I've listed here clinically. It has been. So I think there's a way to do it for any language, to be honest with you. I think it's understanding kind of the principles of the treatment, but then also understanding the specifics of the language. I would be happy if you want to email me to kind of put some feelers out to see if people that have done VNeST in other languages or have more of that language specific knowledge had some insight, because I think there's a way to do it, but because I don't have enough knowledge about that language and those specifics, I'm not sure. But it allows itself, it has to be what's natural to the language. So the idea of it, if this is helpful, is that however these concepts are expressed, right, about who's doing something, right, however kind of an utterance is formed, is what you want to do in the treatment. You modify it for that purpose. It is at the core of semantic treatment. It's about meaning. So I think maybe the way you ask the question or you prompt and a response might be different and very language specific, but principally you should be able to do it. Yes. So if you find out more, let me know, or I'm happy to help find people to help you. I hope that helped. But in principle, I think it should be able to be modified for any treatment or for any language.
Thank you very much. Then a question from Maria Ivanova. Lisa, thank you for a great talk. Can you comment on the balance between number of verbs included in the treatment and number of repetitions with each treated item? Might there be an advantage to covering more verbs during the course of treatment, but with fewer repetitions of each? Or is repeated stimulation of the same verb network critical to seeing treatment effects?
Yeah, no, thank you, Maria. That's a great question. I think it's an open question, to be honest with you, because I think there's a balance. I think the repetition is important, with the caveat that the repetition includes increasing variety. So if we repeat and we have the same responses every time and we're not trying to elaborate, I don't think that that's particularly useful. I also think if we don't do enough repetitions, we're not allowing for the strengthening that we want to promote word retrieval. So I think there is a balance between the two. So we've kind of settled on, and also it's how long you have in treatment. If you have 30-minute sessions versus hour-long sessions, that makes a difference as well. But I do think the depth needs to be there. You have to have enough time to dig down into the meaning that people are trying to convey and to work out any kind of semantic confusion or whatever. So I think if you do too many verbs, you don't have the time to work at that quality. So I think it is a balance. I think it's an empirical question to some extent. But I think the idea is if you can get that depth and you can do it with more verbs, then I don't think there's anything wrong with that at all. It's just a matter of not having it become very rote and trying to go too quickly through the verbs.
Thank you. Maria also had a follow-up remark related to the previous question. In regard to word order, VNeST works just fine, at least based on clinical experience, in Russian, which has a free word order.
Thank you, Maria.
Then we have a question from Kirana Tsapkini. Beautiful talk, thank you. If the mechanism is strengthening the semantics, how does VNeST compare to other semantic treatments targeting lexical retrieval? Is there any comparative evidence?
Well, I think okay, first of all, there might be something out there I'm not aware of. So I want to just say that and not miss something. I think in principle, I think what makes it different from, like, for example, semantic feature analysis is the level at which you're working, right? So I think the most kind of obvious comparison is something like semantic feature analysis. But there you're working usually with nouns and you're creating sort of semantic features around it, and it doesn't have the sentence component to it. And so I think from a semantic stimulation sort of standpoint, VNeST is just working simply at a different level, at that sentence level, but still strengthening semantics. But instead of features, it's really strengthening the semantics between the verb and the other words and creating sort of semantic distinctions as well. There are other therapies that work, though, at the sentence level, like response elaboration therapy and that sort of thing, where they are trying to promote more kind of language production. But it doesn't have kind of the same idea of creating lots of different responses to promote a larger kind of semantic network that you're working on. So I think that there are, I mean, when I developed this treatment, I was aware of things like semantic feature analysis and other treatments, and I took some principles from those, but adapted it to sentences. And so I think there are things out there that have, you know, elements of VNeST and vice versa, but I don't think there's like a direct comparison, simply I think because of all the different scenarios that we elicit. I think that's what makes it somewhat different. I'd have to think about it in more detail, but I hope that gives a good answer. These are great questions.
And we only just got started.
Okay, okay.
Maya asks, thank you for the wonderful talk. Number one, VNeST results look very promising. I wondered if you have any maintenance data. Mm-hmm. And number two, what is your experience with VNeST for people with Wernicke's aphasia?
Yeah. So thank you for asking about maintenance. I didn't include the data. For most of the studies, we have looked at maintenance. It's usually anywhere from 1 month to 2 months. I can't remember for every study. And the maintenance is very strong. Where you'll see the most of that data, if you need to look at it, is in a 2014 paper where we looked at 11 people in a clinical trial. So we looked at post-treatment, and then I think it was 1 month or 6 weeks. I'm sorry, I don't remember exactly. And we saw not only maintenance, but in some cases we've seen an increase in some abilities with maintenance. And I think we've seen that enough of times that it means something, I think, and I think other researchers have seen this as well. I think sometimes at post-treatment, people are actually maybe somewhat fatigued and they're just coming out of a long, treatment study. But also the time between the post-treatment and maintenance gives some time for kind of everything they've been working on to consolidate a little bit, if you will. And so in some cases, we do see improvement even at the maintenance point. So those data are out there, and they look pretty decent. As far as Wernicke's aphasia, that's a really great question. There's a paper that recently came out, Lerman et al., who looked at using VNeST in a person with Wernicke's aphasia. This is a bilingual individual that goes into a lot of detail about the benefits of VNeST with this person. We've also looked at I want to say one person with Wernicke's aphasia and 2 people with sort of kind of like jargon aphasia. And in all cases, they show improvement. What we see, though, is that constraint seems to have an effect on them. So in some cases, we notice that people do really well with sentences. That constraint, they improve on sentences. There's something about the constraint of just focusing on an SVO that allows a lot of improvement. But at the discourse level, they still really cannot manage it. It's just too much to try to do there. So there seems to be some relationship between like the amount of constraint that helps kind of support them, if you will, and how they do. But we've been very happy and surprised by the results. There was a gentleman today I was going to show you with jargon aphasia who showed some really nice improvements with the adapted version. And for him, he had more pronounced comprehension problems. And so we found that the adapted version of VNeST worked really well for him because he could get even more feedback when working at that picture level, and his comprehension improved on sentences from something like 50% to 80-some%. So we also saw some improvement in comprehension. So yeah, there are a couple studies out there. If you want to know specifically which ones, I can point you to those participants. But I think it's encouraging because they can do the treatment, they're engaged in the treatment, and we do see improvements. There's not been any one of them that hasn't improved on at least a couple of the measures.
Wonderful, thank you. Another question from Danielle Fahey. The treatment, and this may tie into your work on other languages as well, and bilingualism. The treatment seems to rely on the semantic network, and for bilinguals, there's theoretically a single lexicon, so cross-linguistic semantic effects might be expected. Have effects from cognate or homonym status been investigated in VNeST? Have effects from cross-linguistic structural similarity or dissimilarity been investigated for bilingual patients?
I don't think there's been anything with cognates at all. I don't know. I think it might be tough to do depending on the language and working with verbs and all that sort of thing. But you could definitely look at that in whatever language you're thinking about if there are a lot of cognates. But no, I don't think it's been done at all in VNeST with cognates. The second question about cross-linguistic generalization, the studies that I know of are the ones I just talked about in the talk. So one with Mandarin and in Hebrew and English. And I don't know the depths to which they went into talking about the structural differences. They did talk about how it was maybe modified in terms of word order to adapt VNeST for that. But the focus, I think, has primarily been on kind of just the generalization and in what tasks. And just like with monolinguals, the results are varied in terms of participant patterns of improvement. So you may see improvement to across languages, but how that manifests is different in different people. And so it's just, you know, exponentially more complicated in people who are bilingual, because of course their backgrounds, proficiencies and use of the languages are very different as well. So I'm not sure I answered your question. I think there's not a lot of literature out there yet. I think if there are more pointed questions about structural similarities or differences, that work hasn't explicitly been done. But I mean, I think it's super interesting. But I think that part, if people are going to use VNeST in bilingual research, we just don't have tons of studies yet.
Great, thank you. If you're still up for it, we have more questions.
Sure.
A question from Wasim Ahmed. Thank you for a wonderful talk, Dr. Edmonds. VNeST could be easily adapted into Kannada language, as it is a morphosyntactically rich and agglutinative verb final language. We had to add new strategies to improve the usage of appropriate case markers in order to obtain grammatically appropriate sentences as the therapy sessions progressed. And we did notice cross-linguistic generalization into other languages in most of our clients. It's more of a comment than a question, but maybe.
Is this the person? I did have one abstract that did use VNeST in Canada. Is that one of the authors, or is this just?
Yes, he says.
Okay, all right, wonderful.
Yeah.
So yeah, thank you for adding that, and I'm glad that it went so well and that you're seeing cross-linguistic generalization. I think that's very exciting. Be honest, it really was, when I developed the treatment, one of the things that I hoped could happen, that it could be used in other languages, because we just need treatment options in different languages. And so that's really wonderful to hear. Thank you.
That's really nice. I had one final, it was a question that I typed while you were giving your talk. I think I missed, or I'm not sure if you mentioned, what is the typical discourse prompt that you use? Like when you talk about discourse, is it free, or tell me about something?
Oh, yeah, I didn't. I can tell you what we use, and I can tell you that we want to do more. So what we typically have been using is the Nicholas and Brookshire stimuli. So these, they have good test-retest reliability, and the pictures that you saw there are all from that. So there are sequential pictures to tell like a short narrative. There are just picture scenes to also kind of describe. There's also personal questions like, what do you do on Sundays? Where do you live? And describe it to me. There's procedural discourse, things like how do you wash and dry dishes by hand? So there are different types of discourse, and the protocol asks that, or there's 10 different stimuli in the original protocol, or you can divide it up into 2 sets of 5. That also are reliable. And so when we look at spoken and written, we break it up into 5. So we have 5 stimuli that are spoken and 5 that are written. And that's what we currently use. Our lab has been working with conversation measures with a previous doctoral student, Marion Lehman. So we've developed conversation measures now and have started to look at those as outcome measures. There was one for ARCS-W that is out and published with conversational measures, because we have some reliable measures. So we want to add conversation for sure in the future. I think we need more, not less, and more ecologically valid.
Great. Yeah, and one reason why I was asking is if I was wondering whether you think some of these different types of discourse may benefit more from VNeST than others, or have you seen that in your data, that some types of discourse elicitation really improve with the VNeST, whereas others may not, because they draw differently on the free word choice of the participant, right? In some cases, it's very constrained.
Exactly. Yeah, I don't think we've teased it out. I feel like there was one time I tried to look to see if there was some kind of pattern that feels familiar. But no, I think it would be person specific, where procedural with the more simpler, sentence structure and drawing on a familiar kind of cognitive, procedural task might facilitate more for somebody, whereas doing more of a narrative might be more difficult for any number of reasons. One thing we do tend to notice, well, I can't say we tend to notice it. Sometimes what we notice is people do better with the pictures than if they don't have pictures, because the pictures do at least activate directly the semantic system by you seeing the visual representations. So sometimes they do better with pictures for that reason, but I don't think there's a clear pattern.
Great, thank you so much. Well, in the chat, we have lots of thank yous and compliments to you. I can send you the chat after we're done.
Thank you.
But that exhausts the questions that were asked. Thank you so much, Lisa.
And I am happy if anybody tries anything new or has questions, please email me. I mean, I really am interested in what you're finding out and doing. Great.
And as I said, our next C-STAR talk will be March 25th, if I'm not mistaken. Dr. Rebecca Jackson will be joining us from London, Cambridge, actually. And so we're looking forward to seeing all of you then. Enjoy spring break and see you next time. Bye-bye.